Thank you, Patty.
You're welcome.
I'll start then. Welcome, everybody. Our community chat this week is about barriers to healthcare women. My name is Elizabeth Staum. I'm one of the community health educators at Montefiore Hospital, and I work with Sandra, who was not able to be here today to host, so I'm substituting for her. And we have two wonderful guests to talk with about our topic today. And I'm going to ask them to introduce themselves, Dr. Michelle Strong and Patty Guzman. So thank you so much for being here, Dr. Strong. Would you mind introducing yourself?
Sure. I'm Dr. Strong. I am an obstetrics and gynecology generalist at Montefiore Medical Center. I've been here about 2 years. I did my residency in Boston, and I love working with the underserved community, and I'm happy to talk about disparities in care in our communities.
Thanks so much. And Patty, would you like to introduce yourself?
Yes, of course. Thank you for having me. I'm Patty Guzman. I'm an allied healthcare professional working at Montefiore in Nyack. I currently am the International Board Certified Lactation Consultant at the Prenatal Center, in charge of clinical lactation for outpatient services in both English and Spanish. I also lead the New Mom Circle support group. I have been involved in managing the virtual childbirth education program and other perinatal related events on behalf of Montefiore Nyack.
Okay, thank you so much for being with us today. So why don't we get started? And I just want to say, any participant or attendees, if you want to ask a question, you can raise your hand, you can enter a chat into the chat, and I will be sure to read it off when we have the next chance and ask our speakers about your questions. So let's get started. So if we're going to talk about the barriers to healthcare of women, first I just want to ask you, both of you, what are social determinants of health? How do these affect women's healthcare?
Defer to you, Dr. Strong.
Sure. So social determinants of health are different things such as race, gender, also socioeconomic status, rural versus urban areas, so where you live, that impact the care that you receive and just your health in general.
Right. Anything you want to add, Patty? Or?
That's exactly it. In terms of CDC and WHO definitions, it's exactly that. So much of our health is determined by where we live, how we learn, how much we've learned, where we work, where we play. And all of this has an effect on our health risks and our outcomes just by virtue of the zip code that we live in.
Right. So what would you say are some of the challenges that women face in receiving healthcare?
Women are unique in terms of some of the challenges, as they are usually the primary person responsible for taking care of their families, especially their children. So, in addition to possibly being a breadwinner for their family, they also have to take into account usually childcare as well in accessing care. And arranging childcare sometimes to access care. So that can be a huge barrier for women.
Right. A lot of competing priorities besides taking care of yourself.
Exactly.
Very much so. Definitely being the primary caretakers and heads of household takes a big toll on women's ability to even get out and schedule their appointments and make their appointments as planned. I would say in addition to that, I would take it a step further, that so much of modern Western medicine has historically been based on men. And studies and research are early research and long-term research studies widely based on men. And so that comes a challenge, and also healthcare's prioritizing of conditions that mostly afflict women or that women are at a higher risk for. So there's a lot of unknown territory, and we're sort of in that expansion and evolution now. Yet we really need women to not only prioritize their care and getting to their appointments, but also be able to speak for themselves, advocate to make sure that what they're hearing and the guidance that they're getting is most appropriate for women in general, and then specific to their own concerns.
Right. Which is interesting since we're, if anything, more than 50% of the population, right?
Yes, and we do see a lot of procedures that, especially reproductive procedures, that have become political places for individuals to, decide what a woman can get and in what timeline, such as like a tubal ligation. There's this, 1 month wait for any woman in New York State, whereas a vasectomy, you don't have that wait. And so that can be a barrier, especially if a woman hasn't signed their papers during their pregnancy in time to them getting the care that they need. And we see many surgeries canceled because the forms aren't filled out correctly. And unintended pregnancies in that aspect.
Oh, that's surprising to me. Is there any justification for that whatsoever, given that those are pretty equivalent situations?
Well, it's a knee-jerk reaction to historical disparities in sterilization of minority communities. So it definitely came out of trying to protect our communities from being sterilized against their will or unknowingly being sterilized, but now has turned into, in some states, New York is unique in that all women, regardless of their health insurance, need to wait a month, whereas in some states such as Massachusetts and California, where I'm originally from, if you have private insurance, you only have to wait 3 days, whereas if you have state insurance, you need to wait a month. But it is a reaction to historical disparities and something that needed to be in place initially.
Right. I'm just going to mention we have a comment that Jacqueline said, it's also difficult to find a physician who will perform a tubal ligation on a woman who hasn't had children. I don't know if either of you want to comment on that.
I think there's like an age, they typically don't want us to do it prior to the age of 21. But I know at Montefiore, if a woman desires this, then we're happy to take care of her or any woman who does desire that procedure.
Yeah. So thinking about these challenges and issues that women face, could the two of you talk a little more about which groups of women are most vulnerable to, having barriers to accessing good health care?
Certainly, as Dr. Strong was speaking, one of the first things that came to mind is exactly that. Pregnant women, early postpartum women, certainly, and through the entire postpartum time frame. Like it or not, during our pregnancy, and I say this as a mother of 3, that during our pregnancy, we are vulnerable, and everyone is different and falls in a different space in terms of level of vulnerability. But the fact is that things change and things are changing quickly. And as a society in modern culture, we are not necessarily preparing our girls and our women for these changes in advance. And 50% of pregnancies are not planned. That's a statistic that's been out there for a very long time and stays that way. And of the 50% not planned, I don't even know what the percentage is of people not preparing, not being encouraged to prepare in terms of the changes that their bodies are going through, the changes that they will experience, not only physically, but mentally and emotionally. And in addition to that, then what to expect truthfully and reality-based in the early postpartum days and weeks and months and even years to follow. And so again, this is an area of discussion and that is evolving at this time, and has been somewhat accelerated by the pandemic because we are living still in this pandemic timeframe. So certainly maternal and infant mortality is a huge issue in the United States, and even more so for African American or Black women, Hispanic women, Indigenous women that have higher rates of infant mortality, maternal mortality, disparities, inequities in care. And it's something that really needs to be addressed sooner.
Yeah, it's particularly these women in our underserved and underinsured communities who, unfortunately, outside of pregnancy, a lot do not have access to healthcare and come into pregnancy with many comorbidities that have not been addressed, as this might be the first time that they've been eligible for emergency Medicaid or any type of health insurance. And we have this window to try to address all of those things. So it already puts them behind the ball. Although we've seen a lot of the research that even when controlling for all of these factors, that there's still higher rates of morbidity and mortality in our communities. But it is, we get this, 18-month window where we have the ability to do all of this preventative care for these women before they lose their health insurance again. And that's where, we see the perpetuation of these social determinants of health. They don't have access outside of this. And, they may not have had a pap smear for, some women ever. And, it's hard to try to catch up and have them have all these extra appointments when they may have already have children at home.
Yes, absolutely. And we see that at Montefiore Nyack Prenatal Center, where a large portion of our population is from the immigrant community, whether it's people who have been here for a very long time or recent migrating immigrants who are late to care. And so without really knowing the extent of the history of the care that has been received, what the needs are currently. And that's part of the bigger picture, and part of what we do at the prenatal center is that coordination of care and services to try and address all of the issues. But it is a huge challenge and a barrier, right, to women's health. Certainly that, and the other group that comes to mind is certainly the LGBTQIA+ community. For persons who are transgender or identifying one way or the other. There's a huge gap in care. And again, Montefiore Nyack has taken wonderful strides in addressing and closing this gap with our Pride Wellness Center. So there's a lot of change that is currently happening and much needed, but it's also encouraging members of these groups to want to seek out the care, to feel that trust and confidence that their specific concerns and needs will be addressed.
Yes, and feeling comfortable in finding physicians that potentially will look like them, or if not looking like them, make them feel comfortable and heard, and trying to address the disparities in health education and preventative services and in vaccinations, so that our communities aren't behind in these screenings and preventative care opportunities that are available, trying to address historical concerns about, being used as research subjects, and that concern in our patients that they're not willing to accept what they're being given because, they're unsure of what it's being used for.
Do you want to take this chance, Dr. Strong, to talk about, you were talking about to us before about cancer screenings, about some information you had. Would you like to do that now?
Sure. I won't go through all my slides, but I can briefly just touch on quickly on what cancer screenings can be done, and then quickly just on some of the disparities that we see. Okay. Let me see if I can get it to move. Okay. So the routine cancer screenings for women that we should be doing are cervical cancer screening, breast cancer screening, and colorectal cancer screening. That's regardless of family history or not. The ones that some may wonder about are ovarian and endometrial cancer screening, so ovarian cancer or uterine cancer screening. And those in particular should be done based on risk assessment, family history. Those aren't ones that should be done as routine cancer screening. Where we're seeing a lot of disparities is our women receiving the routine cancer screening for cervical cancer that should begin at the age of 21. And hopefully, if we're getting regular screening, be able to age out at the age of 65, as long as those have been normal. As well as the uptake in our communities of the HPV vaccine, which should start, they've actually decreased it to the age of 9, but can start around 11 to 12 routinely. The FDA has approved it up to the age of 45, and you can discuss with your patients, depending on their risk and their history, whether or not that is something that they would like to get, and insurance does cover this at this point. In terms of breast cancer screening, where we see a lot of disparities, especially in Black women, it should, per ACOG, which is the American Society of Obstetrics and Gynecology, which some of our recommendations differ from other societies. We begin screening at the age of 40. And this can be with an annual or biannual breast exam with mammogram, and should at least continue into the age of 74. And then for colorectal screening, which we see there's a higher incidence of colorectal cancer in the Black community, especially earlier colorectal cancers. And this was a recent change where the average age, they were used to recommend the age of starting to screen at 50. Now they're recommending, given the increase in incidence in minority communities, starting at the age of 45. This with either a colonoscopy or a stool-based kit, and then up to the age of 75 for routine screening. In terms of some of the disparities, we see some of the biggest disparities in the South in the uptake of the HPV vaccine. We see in the Northeast where we live, especially like in the Rhode Island, Massachusetts area, up to 80% of full vaccination rates, where as in the South, we can see just Mississippi, 30% of those who should be vaccinated for HPV. And a lot of it is associated with probably how the vaccine initially was marketed, as HPV is a sexually transmitted disease, and a lot of parents believe that their children shouldn't be sexually active and therefore shouldn't need this vaccine, but it is actually one of 2 vaccines that can prevent cancer in general. The other being hepatitis B, which can prevent liver cancer. by preventing the infection with hepatitis B. And most parents are not against their children getting their first hepatitis B vaccine while in the hospital as a newborn. However, they are against getting, getting their HPV vaccine. And so with the pandemic, we have seen this decrease in women being on top of getting their cervical cancer screenings. We see the rates between, Black and white patients, as well as Hispanics and American Indians being disproportionately behind, and as well as urban individuals rural individuals also having trouble getting there, as well as uninsured individuals, as we talked about with our patients that only have access to insurance during pregnancies. I could continue on. The same thing is seen with breast cancer screening and also the type of breast cancer screening that is done, and the age of first mammogram in the minority communities, as well as disparities in colorectal cancer screening as well, and the age of first cancer screening. I was even able to find something about New York and how far we are behind in New York in terms of disparities between groups as well. So although there's many task forces that have been created, especially with the glaring statistics on maternal mortality and morbidity, we still have a long way to go.
Are any of these, like the research that you have brought up, do they have specific information around, like, did they ask about why people have not gotten their screening done? Like, have they talked about the specific barriers that they attributed to not getting?
For cervical cancer screening, and the one that I showed in terms of being behind on the cervical cancer screening, one of the major factors that they identified is that women didn't understand how important it was to get that screening done. And so obviously we're seeing a large disparity in health education and understanding healthcare literacy, and which is common in our communities.
Right. Right. It seems like, thank you so much for showing that to us. Just so many parts of the process of going through healthcare, right? From realizing that it's important. I didn't mention that I work at the prenatal center with Patty as well. It's one of the things I do. And so we see so many parts of the process. People, like some of the immigrant women, they don't have an ID. And they can't go unless they have an ID. And so for some of them, it presents a huge challenge. And so they're late to care because of that. There are, parts of the process where you see that, like when you talk about health literacy, just the simple or not so simple process of picking up a prescription at the pharmacy, we see, huge challenges around understanding that and actually being able to, or if there is any type of challenge there at the pharmacy, then the medication will end up not being picked up, right, and not being taken. So, again, like you said, if there are people they can talk to, or people they can relate to, or people that they feel safe with, then there's a point of entry to say, well, this hasn't been working out for me. But if you don't have somebody in the healthcare system that you feel comfortable and safe to trust, then it's so easy for these things to fall through the cracks, right? Or you might have information that is relevant to your healthcare, but you don't feel comfortable to say it, So, yeah. So another question would be, why do women face different barriers to healthcare than men?
We mentioned it a little bit early on, excuse my voice, I'm recovering. But we talked a little bit about so much of healthcare and research is based on men. But really, women's health really should be its own discipline and requires the attention. ACOG research shows that about 85% of women's health providers felt their patients' social needs were as important as their medical care, but about 80% reported not feeling comfortable addressing it, right? So there's this hesitancy from some providers, not all, but maybe still in this day and age, to kind of bring that aspect into the care and have the conversations that need to be had. Maybe it was not part of training or part of early practice, but it's certainly something that needs to change. And also listening to women. I think that women in general, and it's not so much that I think, but that we know, are misdiagnosed more often than men, especially with people of color, Black, Indigenous people of color. But there is this propensity to dismiss a woman when she is reporting on what her concerns may be. Maybe they're very into their bodies and feeling, and maybe not being able to put their finger on what's wrong, but we know what's wrong, or that we know that something is wrong early on. However, we can't be specific about it, and the provider is not comfortable talking more and sort of delving in deeper. And that in and of itself could be a reason, as opposed to maybe someone who's more confident coming in. This is what's going on. This is what I need. This is what I want. And, the realities are the realities. It's a bit stereotypical and maybe antiquated, but there is a propensity, I think, for there to be a difference with how men approach their care and the foundation of medicine versus women.
Yeah. Being more easily dismissed sometimes.
Right. So that may be a why behind that.
And I mean, we talked, for instance, Dr. Strong was just talking about women, receiving their, the rates which they receive their cancer screenings. How in general do you think all these barriers to accessing healthcare for women, how do they affect a woman's health, and how do they affect the woman's family as well?
I do see that, individuals in our community often, especially in terms of presenting with any of these types of cancers, present later and with more invasive cancers. And in talking to many of my patients, and in talking, when we talk about routine screenings, or my patient hasn't gotten that mammogram yet that I, may have sent a referral for, the previous year, I talk about, the fact that your family needs you here. And I understand that, you may have to go pick your child up from school here, and your husband wants this from you here, but if your health is not made a priority, then you won't be there for your family. We talk a lot about that in prenatal care as well, when a woman may not want to stay in the hospital because when her blood pressures are high, because she needs to figure out care for her child. And if I send you home now, you could have a seizure, you could have a stroke, and you may not be able to care for your child. So it's having those conversations and making sure that our patients don't feel like what their obligations are dismissed because they may not have someone else, but also having them understand what your concerns are for their health.
Right. That if they feel like you really understand the challenges that they're facing, and yet it still is really important that this health issue is urgent. And, again, if there were resources to help deal with those challenges that they face, right?
That's exactly right. Just maybe jumping on what Dr. Strong said, and maybe a different way, in a more direct way, is that women, because of these barriers and because of the challenges are at higher risk for all of these diseases, a long list of diseases, and are more likely to die. But no one thinks about it that way. Everyone is in like maybe the now, or the present situation, or what needs to be done. And it's a lot of it is changing the mindset of the actual person to think about themselves first, prioritizing their self-care. That's so much of the conversation that we have in New Mom Circle support groups, within and around pregnancy, postpartum, caring for the infants, growing families and needs. And we cannot pour from empty cups, okay? So we need to pour in, and it starts with taking care of our health first and foremost. And yes, Dr. Strong went through many different issues that can affect women, but here I see that also heart disease, stroke, alcohol-related complications, of course, breast cancer, and even mental health disorders. Women are at higher risk. Women are suffering and just tolerating these things and letting it go far too long. And it is preventable. We need screenings, preventative screenings for women and for other groups that are underserved, right? Going back to the LGBTQIA plus, and the lack of screening, increased risk of cancer for this particular group, and less likely to have access to health insurance and being legally discriminated against in certain circumstances. Those are barriers for this particular group as well.
And I think that if women are earning 82 cents for every dollar that a man is earning, they're working at least as hard, but earning less money. You know, more women are going to end up solely financially responsible for their children as single parents. Or if they're in a couple, more of the time women end up taking on the, you know, a much larger share of the labor at home. All of these things lead to not feeling like you have enough time to take care of yourself, right? So all of these ways in which you can take care of your health, going to your cancer screenings or going to your annual physical exam, you know, going to all your prenatal appointments, these things can get pushed to the side because somehow, you know, so much is already on your plate by, you know, because you are a woman.
And the pandemic just, you know, made this even more glaring with students home from school and mothers expected to be teachers as well as work, you know, as well as attend all their appointments that they can't bring their kids to because, you know, we're not allowing multiple people into the hospital. And so it's made these disparities even more glaring, and made it harder as access to childcare and to mental health physicians. You know, there's shortages of staff across every sector, even especially in hospitals. It's making access to care even harder, especially in our communities.
Yeah. So another question would be all these barriers to women accessing healthcare. What effect do you think that these are having? Like we've been talking about the effect on the women, but what effect does it have on our country's economy, kind of on all of us as a whole?
We see it in all of our staffing shortages and, you know, everything's taking longer. And I mean, they may, you know, we're talking about the job growth and, you know, we see those reports every month, but we also see that a lot of people have not entered back into the economy. And I think it has a lot to do with the inability to find childcare or the inability to find a job that actually pays enough to actually live on. And it's kind of like a vicious cycle.
Right, or jobs that have some level of flexibility so that you can do your work well, but still meet your family obligations, which for many women are larger.
Absolutely. You know, having had, now we're in, completing a second year of the pandemic. And yes, in the last year, things have gotten better and opened up. However, we are a significant part of the workforce. I won't try to quote a percentage, but the facts are we are. We are also heads of households, maybe lots of single parent households, or even if it's a dual household, the women's earning ability and her spending ability has a huge impact on the economy, and we're seeing that now, right? And just a word about the flexibility. So much has been, I think, learned about our ability to provide support and to reach people using the technology, adapting our processes to incorporate the technology that we have, or the programs that we have access to, being able to expand our use to make it more convenient for women, I think is where it's going. And it's a smart move, because we need to be able to move forward. We need to rise up out of this situation, this collective experience and trauma, really, that we've been going through as a world and as a country, certainly. And I think it remains to be seen how all of that will play out. There's a lot of discussion about the great resignation, where people are just not willing to sacrifice themselves as much. Now, seeking out healthcare and following through healthcare is one thing. The economy and the workforce is another. And trying to figure out what life is going to look like now. What is that new normal going to be? And try and take some of the positives that we've gained out of this time period and the acceleration that so many sectors have experienced with the use and integration of technologies.
Mhm. Patty, would you be willing to say a little about how you have used technology as a lactation consultant? Because the women in the prenatal center have a lot of challenges around their employment or around the childcare and being able to come in for appointments. And you've really, done a good job of using that to benefit them.
Thank you. Thank you. Yes, I would. As the lactation consultant at the prenatal center, where we offer education and support prenatally and through 6 weeks postpartum, it's just such a key time frame. And when COVID hit, like COVID happened to everyone, right? And we may not all be in the same boat, but we've been in the same storm. And so if I speak to the work that I do day to day there, very early on, as we were, for our patients' safety, wanting to find other ways to provide services, introducing telemedicine and telehealth. At first I'm like, well, what is it? I thought it was like one thing. And I just quickly had to adapt, right? Quickly figure out, how am I going to do my job and fulfill my role to the best of my abilities when women's appointments are happening more through telehealth in general, in terms of their routine appointments, maybe less appointments. When they do come in, we're not necessarily keeping them as long for the additional services, because both nutrition and lactation are seen as additional extensions of care, but still so necessary. So I personally just made it my business to learn, what is telehealth? What is telemedicine? How to do it? What are the various platforms that are available as a lactation consultant? And to be able to bring that to my management and recommend and suggest and ask for approval and access to these tools. And it just so happened that, already management was ahead of the game. The Zoom healthcare was already readily available. And so it was a quick turnaround within 1 to 2 weeks, really about 2 weeks of learning what it is, how to do it, teaching myself the tools. I personally, lactation is a very traditional discipline, in-person, hands-on, always has been. And all of my experience and practice had always been in that capacity, whether at the maternity center or the prenatal center. And to have to learn, like, how do I assess, consult, educate, support, and promote lactation via a tool such as this. But it is possible. And even with the underserved segments, even with segments that may have limitations, everybody has a cell phone, right? For the most part, 99% of people in general will have a cell phone, will have Wi-Fi access. And it was teaching myself, also teaching the patients. The conversation would start with, because of COVID, we've had to make these changes, yet this is how we can help support you. Are you open to, are you wanting to try? Have you tried, video conferencing of any type? It's like WhatsApp, it's like FaceTime. It's a little different because we're using, Zoom Healthcare, HIPAA compliant. And that was really interesting. And it went from being maybe a 15 to 20-minute conversation to being 5 to 10 minutes of getting the patient interested and acclimated and plugged in to be able to deliver the services. And then getting very creative and well-versed with being able to do the observations, being able to demonstrate and see the return demonstration from mothers when holding their babies, positioning their babies, and giving that guidance, addressing any needs or special concerns that are more clinical. And all of that was a learning progress. How do we take how we teach and integrate that into a consult? And I'm so glad to report that it worked. We had no way of knowing, but we were able to get it done. We were able to bring the patients along, the large majority. And for anyone who really couldn't, whether it was, a mental barrier or an actual physical technology barrier, then we could take the appointments in person using all the precautions. But the reality is when it comes to lactation, most of the challenges are normal course of breastfeeding challenges. Most of the challenges are mindset, education, information, and then intention. And that's where most of the work lies, that we can talk about that certainly over the phone, and even better when it could be in a sort of face-to-face. And the last thing I will say is a good silver lining was to be able to reach those mothers, those families that were COVID positive, were quarantining, were alone in their rooms at a vulnerable, but also very special time in their lives. And being able to reach moms who were quarantining themselves from their babies unnecessarily, bringing them the guidance and the recommendations, and to be able to be that face and to be that connection to the outside world, that they're not alone. And that really was at the crux of it.
Yeah, thank you. Dr. Strong, I know a lot of things you do are things that, absolutely need to be done in person, but I'm curious about, as we're thinking about, the barriers to healthcare for women, has telemedicine played any role for your practice in terms of being able to deal with these barriers?
Definitely. I mean, similarly to what Patty said about us having to transition, it was transitioning every other prenatal care visit, as long as they were low risk patients, to a virtual visit, and providing blood pressure cuffs to women so that they can, take their blood pressures at home and things like that, as well as making sure that our patients had a visit that they could receive results. So if they had a pap smear, or they had a procedure in the clinic, they would have a virtual visit in order to receive those results and ask any questions that they may have. And so that's something that we may not have had access to without telehealth, to bring every single one of those patients back in to discuss results, and them having the opportunity to have that time set aside for them to have that discussion with the provider.
Yeah, that's great. I also, in the nutrition context, have found that there are patients who have issues that might be identified after their prenatal visit. They're not coming back for a month, but when they have the option to do a phone or a video visit, they can then, be able to have that appointment. It doesn't matter if they have someone to take care of their kids, and, they can have their issues addressed quickly. We also do a postpartum diabetes prevention and weight loss group for the women. And since COVID, we transitioned it onto Zoom. And that's another area where I've seen many more women able to participate on an ongoing basis because they don't have to bundle up all 3 of their kids and drag them over. And so, I think it does increase accessibility that can help with some of these barriers that women face to going to their appointments or getting, help with their health issues.
Yes.
Yeah.
Talk to many a woman at the grocery store or, in the car, picking up their kids. And while it may not be video, we've been able to at least try to address whatever concern they have and decide whether or not they need to come in for an in-person visit, or if it can be addressed with this appointment virtually.
Yeah. So are there any other ideas that the two of you have? We've talked about all these barriers for women, childcare, a lot of burden of work being on them, and economic issues, or their, sexual orientation or gender, all of these things. Do you have any other ideas for what we can do to help women overcome barriers? Or Patty, you brought up the whole, research being more oriented towards men's health needs. What is needed so that we can get, overcome these barriers and get excellent healthcare for women?
I'm certainly a strong proponent of advocacy, right? Education and support. It's multi-pronged. There's no like one way or one answer or broad brushstroke. It's the needs are as unique as the populations are within a subset of women. And we need to be advocating, not only advocating within our organizations, but also for policy changes that are going to help women get more access to health insurance, to the proper care, teaching patients and getting them comfortable about self-advocating, that they have a voice, that they have a role in their care. And they're really at the center of that. That's the concept of the circle of care, and that the patients and certainly for mothers and families are at the center. And they have so many different avenues for help and for support. Their family, their friends, the doctors, allied healthcare professionals, community support groups, community resources, churches, and encouraging mothers to think about it in that way. I say mothers because I'm very heavily into perinatal support, but women in general certainly need that. Any underserved groups need that. They need to know that they matter, that they're a priority, and that they are entitled to ask and request and expect the kind of care that they deserve. And a big piece of that is education. Education all steps of the way, not as any provider, whether it be the doctor, educator, healthcare professional, giving the information to the person so that they can make informed decisions and be part of the decision making when it comes to the recommendations and treatment and care, and to speak up for themselves, again, with the advocacy. And then down the road, throughout every stage, providing the support, creating safety nets of support, whether it has to deal with, postpartum or mental health or recovery of any sort that's happening, letting patients know where they can go to receive this in the organization, as the institution, and also in the community, getting to know, referring out, giving warm transfers. It can't be for every single one, unfortunately, but definitely those that are in highest need, highest risk, non-compliant, opening up that conversation and holding their hands a little bit until they get on their way. I think it's very important to overcome the barriers.
Right.
very much agree with everything that Patty said. And a lot of it is, educating our patients and our communities about what we face and what they should be receiving and what they need to be receiving so that they can advocate for themselves and as well, and knowing what they should be getting at a certain point and when. And it starts early, and it shouldn't be, once a patient is now a mother or soon to be mother, we have to start earlier and, create young women who are able to advocate for themselves, speak up for themselves, and know that there should be policies in place to address the disparities in research, just address the disparities in access, to be able to address these things. I think a lot of it starts with education, and not just within our communities, but within other communities as well.
Yes. It's important to speak up and important to speak out, and continuously in various circles. Absolutely. And I love what you said, Dr. Strong, about starting early. That's so much that's lost, I think, with modern society and living, and especially with this pandemic, is that we live our lives, and in certain portions of our lives, we are living it in isolation, right? So that, through the generations and growing up, unless a mother's having multiple children, even young children aren't really able to see or are as exposed as maybe we once were as a people, right? So starting with the youth, and, if it needs to be a more standardized approach, but in the schools, have the conversations early. And some of those conversations are happening. I have children in elementary, middle school, and high school. And so we get notices at home, and there are going to be sensitive topics discussed. But it's okay. Normalize the discussions, normalize awareness, what it looks like as early as possible, in an age appropriate way. But certainly by middle school and high school, above and beyond simple sex education, we need just general facts of life education.
Yes.
So that it's not a big surprise. That's what we're finding with adult women, young adults, teenagers, young adults, even mature women, advanced maternal age women are totally blindsided, if and when they do decide to become pregnant, or if they're having any sort of health risk. I think we're in a reactive mode in our history in terms of our healthcare, and we need to be getting proactive, right?
Yeah. Oh, you have hypertension. Now let me tell you what hypertension is, as opposed to these are the possibilities of things that can happen to you as you get older, and these are the ways that you can prevent them. And so
family history, getting into that's part of the conversation. And yes, it's touched upon and it's on forms and things like that, but is it really top of mind, right, in the practice and care? What all that means, that's part of the social determinants as well. Where you grew up, where you live now, what are your plans, all these things come into play, and it takes time. It does take some time, but it is well worth it.
Right. And I think there are different, we talked a lot about the, challenges in the kind of maternity, pregnancy and maternity stage of things, but there are, there are things you don't know and people don't tell you. And then once you give birth, you're surprised. And if you had known more about it, it would have been more manageable. I think these things can happen too, as a teenager, right? Some people have lots of access to information about ways to prevent pregnancy, STDs, things like that, and feel safe and comfortable, have somebody safe to talk to. Other people don't have access to that information, don't have somebody safe to talk to. And on the other end of things, I think it's similar with menopause. Some people don't have a lot of access to information about what to expect, or, that you might feel different, that you might need to balance your life differently. right? That there might be resources out there to help you. You know, some people have some access to that information. Some people really don't, right?
Yeah, and and that's absolutely right. And even, we've talked so much about, and rightfully so, about underserved communities, but even people who have the access, we are living in the age of like overwhelm when it comes to information. And there's lots of misinformation, always has been, always will be. And sort of to be able to navigate that. So yes, it's good to seek out the information, but beware of Dr. Google or Google University. Seek out the professionals that are educated and trained and practicing and well-versed in whatever area of expertise it is. And encouraging people to lean on that, right? So yes, inform yourself, gather the information, but learn to discern, be discerning in what is actually accurate. Know your resources, trusted, reliable resources, because anybody who has a certain train of thought can find anything out there to support it. By God only knows who.
Of course.
Right. So certainly yes, informing and self-advocating, but I do believe in, even with education, instructor-led education is valuable because of all the things that we just talked about. You know, it is, one thing can't replace the other. It should just all be in unison, ideally, taking all the parts, moving parts, and seeing what's best for the person and what lands well with them.
Mhm. So we need more research around women's health issues. We need education. We need more resources, right, around equal pay and childcare. And we need a healthcare environment where healthcare providers are really listening to everything that is going on with a woman, so they can really address their needs. Yeah. Well, I thank you. Are there any last comments that the two of you have before we have to finish up? Because I know we have just a minute or two left.
I think we talked about a lot of the negatives, but we are making strides, and there are providers that do want to provide this care to women. I mean, part of the reason that I am where I am is because I wanted to be able to provide care to women in communities such as the one as I grew up in. And so if we can continue to reach back and pull those that want to do the same up behind us, we can continue to make strides in caring for individuals in our community and addressing some of the disparities that continue to manifest in our communities.
Right.
Yes, that's absolutely right. I agree. I mentioned earlier about the movements evolving. We're in this period of evolving, and sort of a silver lining of COVID and adapting and this increased use of technology in this way in day-to-day life is that the voices are amplified, right? The conversations are happening, but now it's more readily available and collectively available for anyone who's interested, right? So it's finding that, every person plays a role, everyone, when it comes to supporting women health care, addressing the issues. We can all be part of the change, and change is happening.
Yeah. Well, thank you both so much for being here. I really enjoyed our conversation. I'm sure our attendees did too, and it was really great to hear your perspectives. Thanks a lot.
Thank you. It's been a pleasure. Thank you.
Bye.
Okay, bye-bye.